All right, hello everyone. This is Melody Stratton. I'm a second-year cardiology fellow at Largo Medical Center, so hi to my Largo people. I'd also like to thank the rest of you for joining us today. Pooja is a fellow, and I'd like to welcome her as well as everyone else from the West Florida HCA division who is also joining us today. I have Dr. Harrison here and Rob, who's helping us with the internet. So I'm going to go ahead and get started. Thank you for your patience with our technical difficulties, and hopefully these will get worked out with time. So let me change this so that you can see my screen. All right, so you should have my PowerPoint up right now. Okay, so I'd like to start out with a case presentation. We have MN, who is a patient that initially presented several years back. He was age 56 at the time. His biggest complaint was palpitations that he'd been experiencing for 2 months. They were happening on a daily basis, and he couldn't think of any triggers. Didn't seem to be related to exertion, position, caffeine intake, anything like that. Interestingly, he was a very physically active guy, though, and said that he didn't notice him quite as much when he was exercising. Whether it was because he was simply more focused on his exercise, we're not really sure. Past medical history was pretty benign. He had been told that he had a heart murmur in the past, but had never been given an official diagnosis. He had had a knee surgery and a negative heart catheterization several years previously. In terms of social history, he was a former smoker, but had quit many years back. Had 1 to 2 drinks a couple times a week and denied any illicit drugs or caffeine supplements. Of note, he was an active runner and hiker and biker. He hiked the Appalachian Trail, did cross-country bicycle rides, was very physically fit. Family history. Sorry about that. I think we got the feedback fixed. Okay. Family history was significant for rheumatic fever and valve replacements in his father, who had died at age 68. His mom had a motor vehicle accident but had no cardiac history of which he was aware. Medications, nothing cardiac-wise, and had no drug allergies. So I would like to get some audience involvement here if we can. I think Pooh is going to help us out with giving us an EKG read. So Pooh, let's see if we can get you to tell us what you see here.
I mean, it's sinus rhythm to start off with. Axis is leftward, but not exactly.
Pooh, are you able to hear us?
Yeah, I can hear you. Can you hear me? Hello?
Hi, I can hear you now. Sorry about that. All right. You want to tell us what you see on the EKG?
Sure. It's normal sinus, vesicular P wave. Axis is leftward, but not like going towards left because leads to is positive. Then there's LVH by voltage criteria, whether it's AVL or by Carnell or whichever, V1, V2, so there's LVH. I'm trying to look for any like Q waves, deep Q waves or something. I don't really see them. Then rate rhythms, heart rates on the slower side, say 350, 100, about 60. Some repole abnormalities, but LVH is what stands out in leftward axis.
Okay, awesome. I think you hit the key points there. So as she said, we have sinus rhythm, heart rates around 60 beats per minute. There does appear to be some possible left atrial abnormality here, as the P wave is very wide in lead 2 with a bit of a notch to it, slightly biphasic in V1, and then the LVH by Cornell criteria, as she mentioned. I think so. A year later, we have another EKG, which now has a different rhythm. I'll go ahead and read this one. Okay, Dr. Harrison would like to ask Pooh to read this one again. Sorry, Pooh, go ahead.
So now it's more like sawtooth, flutter. Oh, it disappeared. The EKG is gone from my screen.
Sorry about that. Let me go back.
Okay, so we see sawtooth wave pattern, more like atrial flutter, right bundle branch morphology. So RBB. And pretty much, again, axis is leftward. So he went into looks like flutter with variable block and right bundle branch.
You got it. Thanks. All right. So now I have some echo findings that I'd like to take a look at. This is actually from a couple of years after he initially presented. So we have here an echo. You should be able to see this on your screen. I'll click through this, and then you can interrupt whenever and give us your thoughts on it, okay?
Sure. So LA is dilated. There was some MR. LV borders, I think. Looks like some
Okay, I know this is hard to do with me controlling it. Let me find a couple of the images that I thought were the most revealing.
basically I see like LVH, there seems like MRs there, LA is dilated. There seems to be a gradient across the LVOT.
Agreed. So I'm trying to find the gradient films here, and I'm losing them. All right, I'm having difficulty here, so I apologize. All right, so clicking through here briefly, as Pooh mentioned, the left atrium does appear to be dilated. We're looking at a parasternal long axis view for our students and nurses. We have our aorta here, left atrium here, and left ventricle out to the side here. Even from this view, it does appear that the septum is a bit thick and seems to be encroaching upon our left ventricular outflow tract from this view. Here's a measurement of our left atrium. Aortic root is also mildly dilated. There does seem to be trivial AI on this shot, as well as a little bit of mitral regurgitation. Here we have a four-chamber view, starting with the apex at the top, left ventricle, left atrium, right ventricle. This is
Do you think that the apex is not coming in as well?
Yeah, it does seem to. Where is that?
Yeah, like all other basal mid portion seem to be contracting well, and apex doesn't seem to be coming in much. Yeah, here.
Yeah, I agree. All right, here we have a two-chamber view, left ventricle, left atrium. And again, it is hard to see the apex on this shot, but probably something funny happening there. All right, I don't have awesome gradient measurements here. However, on the patient's initial echo, he was noted to have a very high gradient across his left ventricular outflow tract of about 56 millimeters of mercury. So at this point in time, we discussed, and the patients had septal hypertrophy, measuring out about 14.5 millimeters at that point in time. Posterior wall was normal at around 11 millimeters. So he was diagnosed with hypertrophic cardiomyopathy with a significant resting gradient. So at this point, I'd like to see if we could get a little discussion going on, but what would you guys consider next? Medications, further testing, what should we tell him about his activity level, and then do we need to recommend any implantable devices for this patient? Anyone have any thoughts?
You said the resting gradient was how much? 50?
56 millimeters of mercury on resting.
Yes. So that's anything more than 30 is significant. Like 50 at rest is significant, or 50 with exercise, 30 with rest. If resting 56, that's
right. It's definitely a hemodynamically significant gradient there.
Significant. I guess further testing to kind of confirm, because if it is significant, like we do label him as HOCM, then we need to tell him, okay, restrict some kind of like mild to moderate activity. He shouldn't do strenuous physical activity. Devices, I mean, unless he's had VT, syncope, like all those big or family history of sudden cardiac death or anything, we're not there yet. But I guess with further testing, or if we get more history, we might get there.
Okay, so you're absolutely right there. Let me have Dr. Harrison tell you a little bit about what we did in terms of testing here as well. First of all, we started out, like you said, with a stress test to see what his exercise capacity was and to find out what happened with his gradient at stress. So Dr. Harrison came up with a modified Bruce protocol, which I'll have him tell you about.
Modified Bruce. What is it, Dr. Harrison? Your modified Bruce protocol?
Hey, Pooh, basically what we decided to do, since he's going to hike the Appalachian Trail, was to have him do a stress test with the Bruce protocol with his backpack on, with the usual weight that he has in his backpack. And I think that's somewhere around 65 pounds, which is a standard backpack weight that the military uses, as well as it goes all the way back to Greek hoplite soldiers, using 65 pounds as the backpack carrying weight. So anyway, that's what we got to do, and we can tell you more about that.
All right. So this was something I had never heard of having done before, but the patient was put on the treadmill with his backpack, and he did pretty well, actually. I think he went about 13 minutes on the Bruce protocol with the backpack. The echo portion of the exam did show that his gradient worsened significantly with exercise and actually jumped up from the 56 millimeters of mercury to about 83 millimeters of mercury post-stress. So very, very significant gradient. However, he was asymptomatic during his stress test. So at this point in time, so at this point in time, we went ahead and started the patient on a beta blocker to see if we could reduce his oxygen demand, get a negative inotrope on board to reduce the amount of a gradient across. And in terms of the counseling on physical activity, it was difficult in this guy's situation because he was such an avid hiker and everything. At this point, we went ahead and ordered a cardiac MRI to see if we could assess, further look at the function and see if there was any fibrosis, scar, things like that that might affect his risk of cardiac death further. So Dr. Harrison is going to show you these images.
Hey, so this is Eric Harrison, and this was in 2011. This is a cardiac MRI, and we started doing cardiac CT in 2004, and then in 2006 we added cardiac PET, and then in 2008 or so we added cardiac MRI. This was early in our use of cardiac MRI, and we took a outpatient radiology diagnostic center here at Memorial Hospital, which had PET, CT, and MRI, and we turned each piece of equipment into a cardiac testing instrument as well by adding pieces here and pieces there. We'd add a gate, we'd add a computer, we'd add a cart for rubidium, and so for about $300,000 or $400,000, we were able to take a diagnostic outpatient cardiac MRI, CT, and PET center and turn it into a cardiac MRI, CT, and PET center. And so here's our first MRI image of late gadolinium enhancement. And maybe Pooh can take a look at this and see what she thinks of it.
I'm not too familiar with reading cardiac MRs, but I'll give it a shot. I guess we do see some septal hypertrophy, but can you orient us a little bit as to how this cut is taken, what all we...
Sure, I'll be glad to tell you more about this, and this is part of our learning experience, is to introduce you to new technology. And so this is looking at a short axis view that looks like a coronal view mostly, where we've got the left ventricle nulled. And so we were able to make the left ventricle, the muscle densely black by nulling it using something called a look locker, which is technical speech in cardiac MRI. So you see how densely black the myocardium is. There are two areas that aren't so densely black, and those are the insertion points of the right ventricle. And so we got an insertion point up here, and we got an insertion point down there. And so that represents collagen-type tissue. And so we're looking for scar tissue, and scar tissue in the septum has been documented as being indicative of increased risk of ventricular arrhythmias in HOCM. And so looking through this interventricular septum for scar tissue and trying to match it to the color of the insertion point, which is very bright, of the right ventricle, we really don't see any scar tissue in there of any importance. And so let's go to a long axis view, and so we'll show you that. And so the long axis view is very pertinent to what Pooh pointed out in the echocardiogram on the long axis view. And so basically that is that the apex has significant apical thinning. And so as you see, there is no apical muscle, and the septum comes down all the way to here, and the posterior wall, inferior wall comes all the way to here, and then there's this apex that actually, it's not that it's been damaged, because if it was damaged, we would see very bright white myocardium coming through here. It would be as bright as the external epicardial tissue is, or as fat is. It would be very, very, very bright. And so it's not. And so this is a bizarre representation of the ultimate apical thinning, where there's less muscle at the apex, as opposed to being an area of damage to the apex where the muscle outgrew its blood supply, both in terms of deep penetrating arteries as well as in terms of the Bechian veins supplying oxygen subendocardially. And so it turns out this is an anatomical variant in its extremis, which is certainly illustrated by the fact, we'll show you later, that the left ventricular cavity is sort of obliterated during systole because it's a hypercontractile left ventricle, as we see in HOCM, and left with an exaggerated apical thinning, as opposed to having in patients who have tunnel left ventricle, which is the Japanese variant of HOCM, where they get apical aneurysms and apical infarcts with remodeling. And so that's the conclusion of our very basic late gadolinium enhancement study in 2011. And we don't have other studies on this particular patient from MRI because we were just getting started and exploring cardiac MRI and its use, and this was the most important thing we wanted to look at that time. So I'll give you back to Melody.
All right. Hello, everyone. you who, like me, are kind of overwhelmed by what the heck we're looking at here and all the different components of this. So hypertrophic cardiomyopathy tends to present a very heterogeneous pattern. There's a lot of patterns. There's a lot of different components to it. The two clinical issues we have are left ventricular outflow obstruction, and then we also have an increased risk of arrhythmia and sudden cardiac death. So we have to balance those two factors. Also, this is the most common heritable cardiovascular disorder and the most common cause of sudden cardiac death in young patients. It affects up to 1 in 500 individuals, so it is a fairly common thing. One of the other things that makes this hard to find sometimes is that it's an autosomal dominant pattern, but it does have incomplete penetrance, meaning that even if you carry the genes for HOCM, you may or may not express them, and the degree to which you will express them may vary a lot. The mutations in genes, there are several, but they deal with the sarcomeric approach, which makes sense since we're dealing with hypertrophy of the muscle of the heart itself. So some criteria for diagnosis: a LV wall thickness at end diastole of more than 15 millimeters, or a ratio of septal to lateral wall thickness of 1.3, along with the absence of another condition that could be responsible, such as uncontrolled hypertension, severe aortic stenosis, or some other infiltrative disorder. There are genetic tests that can be done, but they're because it will just tell you the presence of the genotype, it doesn't necessarily correlate with phenotype. So just to demonstrate the measurements here, I have a CT example of a HOCM where you can see we have a very thick septum of 24 millimeters, and the posterior wall is pretty thick as well. Also, as you will note on here, Dr. Harrison is wanting to point out these small areas you can see in here of light color on here, which could represent tiny infarct patterns. We have these dark microinfarcts, or fatty replacement, as he would say. So many variants of hypertrophic cardiomyopathy: symmetric or concentric. Asymmetric is the most common, where we'll see the septum being more thick than the rest of the heart. There are also midventricular, apical, and focal variants as well. So here's a schematic representing that. A is a normal heart, where we have pretty equal thickness of both sides of the heart. B is a septal hypertrophy with a sigmoid type septum, where the top part bulges out here. C is hypertrophy of the septum, but more lower down in the ventricle. D is an apical HOCM, where we have the classic spade shape appearance of the heart. E is a concentric, where everything is really thick. F is the mid-cavitary hypertrophy. G is what's called a mass-like or focal hypertrophy, and then H is multifocal, where there's two discrete areas of hypertrophy. Pathology is what you might expect, where you have increased wall thickness. There can be scattered fibrosis. The mitral valve apparatus might be thickened. There can also be, on the microscopic level, herringbone and pinwheel type patterns. And we also tend to get small artery dysplasia and narrowing, which becomes important later on when these patients begin to develop microvascular angina and microvascular ischemia because of this small artery disease. So as Pooh had mentioned a little bit of these earlier, the high-risk features that can predict sudden cardiac death. Patients that have survived cardiac death obviously are at risk for having a second arrest. If there's a family history, if the patient has a history of unexplained syncope, if you can catch non-sustained VTAC on a Holter monitor, if there's an abnormal blood pressure response to exercise, extreme hypertrophy, meaning a wall thickness of more than 30 millimeters, or some certain high-risk genetic mutations, troponin T seeming to be the most high risk that I could find. In these patients that have these high-risk features, it's been found that they will benefit from having an implantable defibrillator to protect them from the sudden cardiac death that may become an issue. One thing that I hadn't really had a good feel for is the progression of cardiomyopathy, and I know that always in the hospital, whenever we see it, we're trying to find out do they have it or not, but there's actually a spectrum of this, and it's quite fascinating, really. So stage 1 is actually labeled as being non-hypertrophic cardiomyopathy, where a patient will have the genotype but may not yet be expressing the phenotype. There can be some subtle abnormalities that are nonspecific, like diastolic dysfunction, left atrial enlargement, and mitral valve abnormalities that can easily be missed or dismissed early on in their case. Microvascular disease can sometimes come up, but it's controversial as to what to do with this. You know, you might want to start thinking about a calcium channel blocker, an ACE or an ARB, a statin, things of that nature, but it's not been well studied. Stage 2 tends to be what we usually see when we think of hypertrophic cardiomyopathy, where they have the classic phenotype. They now have hypertrophy. They meet the criteria for having hypertrophic cardiomyopathy. Most of these patients will have actually a hyperdynamic ejection fraction, but the other abnormalities will become more pronounced. Mitral valve abnormalities, outflow obstruction at either a subaortic mid-ventricular or right ventricular level. Coronary bridging and myocardial crypts can also be seen, which I think I have a picture of. This is a CT image showing myocardial crypts in a short axis view. You can see these little black, again, microinfarct areas, as we saw in the previous study. So treatment of this, you tend to get focus on decreasing the outflow gradient. So negative inotropes are going to be the mainstay of therapy here, with beta blockers, non-selective beta blockers being the best, calcium channel blockers, and disopyramide, actually. This is a medication I had never seen used before this month. It's a class 1 antiarrhythmic and does have marked negative inotropic effects that have actually in some studies been shown to be superior to the beta blockers and calcium channel blockers. I think there was a Toronto study that showed good results there. Then there's the surgical therapies like septal ablation and myomectomy. But these patients, for the most part, have a fairly low cardiovascular mortality, about 1% per year. Stage 3 is when things start to get nasty. Fortunately, only about 15 to 20% of HOCM patients will develop stage 3, but this is where they start to get fibrosis in a sort of scattered pattern. Their ejection fraction may still be normal, but it's no longer hyperdynamic. The diastolic dysfunction will progress, and interestingly, their outflow obstruction may come down, actually, or be lost completely. Other cardiac findings will be onset of AFib. They can get moderately sized areas of late gadolinium enhancement, apical aneurysms, and the mortality does go up if patients reach this stage with a cardiovascular mortality of 3 to 5% per year. Treatment, again, is not well studied, and with the loss of the gradient, the question, do they actually need the negative inotropes? Possibly not. ARBs or even Ranexa or ranolazine have been shown to have some possible effects, but again, not really well studied. Stage 4 is defined as overt left ventricular dysfunction. It's sometimes called end stage or burned out phase. Again, only about 5% of patients will progress to this, which is fortunate. And these patients, their ejection fraction has now dropped to less than 50%. They have extreme fibrosis. Left ventricle is now dilated and sometimes will even begin to thin out in these patients. Their outflow obstruction is lost, but they have a very high rate of heart failure and mortality with about a 10% per year risk of sudden cardiac death, which obviously is not a good thing. So treatment for these patients, basically your heart failure medications, beta blockers, ACEs, ARBs, aldactone diuretics as needed, and defibrillators for prevention of sudden cardiac death in these people. And if they have an apical aneurysm, anticoagulation may be indicated to prevent thromboembolic phenomenon. So a couple words on different imaging modalities. Hang on a minute, I'm going to mute myself again.
Very good, Shannon. Thank you.
Okay, so different imaging modalities that we can use. Echo is most well described and classic. It's nice because it doesn't involve any ionizing radiation. Unfortunately, it can be difficult to visualize the apex and some of the different less common types of HOCM. It is nice because we can get serial measurements. We can get hemodynamic measurements in terms of the outflow obstruction, but as I mentioned, may miss apical aneurysms or apical hypertrophy. CT is a nice one because it's not dependent on our acoustic windows. You can get visualization of the apex, and you can assess the coronary arteries. Unfortunately, we cannot use it in the presence of a defibrillator in most cases. You can't assess hemodynamics, and there is radiation involved. Cardiac MRI is newer on the scene, but it has a lot of benefits. We can get accurate measurements, there's no radiation, and we can get hemodynamic measurements, which is fantastic. Also, the late gadolinium enhancement that we can get can also provide us with a lot of information about fibrosis and help us to differentiate from other cardiomyopathies. It can be used with prognostic information. It can be used to assess the efficacy of alcohol septal ablation, but it can't be used with most ICDs. On that note, Dr. Harrison has another MRI study that he's going to show you, so let me switch this over to him.
Thank you so much. I'm switching over to here.
We're going to show you the MRI on this gentleman. This was an MRI that was done October 6, 2015. So you can see that we've evolved a long way in terms of cardiac MRI, because I'm going to show you a whole series of MRIs. And so this is a first black blood series that we're looking at, where we can actually flip through and look at these images. And I've taken the time to measure the septum, which you see is 20.3 millimeters, and the posterior wall, which is 11.5 millimeters, giving a ratio that's greater than 1.3 of septal to posterior wall, which basically qualifies for HOCM by definition, greater than 1.3. Let me show you some more images, and let me flip this up without, and we should be able to flip through here. Okay, great. We're flipping through some of these images. This is the black blood, and when we flip through the black blood images, you can see several things. Here's the main left coronary. Here's the left anterior descending. Here's the circumflex coming off. And as we go around, usually you can see the right coronary origin as well. And here it is up here. And left ventricle, right atrium, left atrium to get you oriented. Here's the spine posterior. The way you recognize that this is an MRI and not a CT is that the spine is not brightly white like the skeleton is on CT. So it gives you a quick recognition. Let's go look at other images that we have. And so here's a cute one, because this is a Cinefilm. And so we're going to animate this. And you can see this extreme example of apical thinning that you see so often on SPECT scans, and you wonder if it's a defect or not. It wouldn't be reversible, but you know, the defects are very hard to read on SPECT scan. And so it's not that this muscle's been infarcted, because we didn't see late gadolinium enhancement. You can see the muscles beating symmetrically all across the board. You can see there's almost obliteration of the cavity of the left ventricle. You can see the mitral valve appears to be fairly competent. There is a little mitral regurgitation that's taking place, not much. Let's throw some more images up, and you can see the great variety of imaging we can do. We're not limited to one window, as opposed to echo, where we have maybe 3 or 4 windows or window limitations. In terms of CT, we can see everything all the time, depending upon which way we want to go and how we want to do perpendicular images to the previous scan. So now you can see that during systole, there is a subvalvular area of high velocity, which is marked by this null area that gets very dark during systole. And so we can actually stop that, and we can move into where you can see it with the valve closed. And the valve is closed, the mitral valve is closed now, and we get this ejection of blood, and this is turbulence that gives you this null black area, and it's all beneath the valve. And you can see the aortic valve is thin, gossamer, entirely normal, and we can actually measure this gradient with phase. And we'll show you that in just a minute on MRI. Most people don't understand that we can actually measure with MRI gradients that people have, just like you can do with echo. And so this is looking more at slices of the left ventricle, and we use this for measuring left ventricular volume. I'll show you some more pictures. And here's another action film that looks like a 4-chamber view, where you can see mitral valve, tricuspid valve, left ventricle, right ventricle, contractility, left atrium, right atrium, interatrial septum. Beautiful picture showing the potential of being able to look at many images and many different views with cardiac MR. Here's another one for you that is a 3-chamber, like you might see on echo, looking at the left ventricular outflow tract. Again, making careful observation that during systole, there is a subvalvular turbulent area beneath the aortic valve being normal, and the turbulent area is right here between the septum and between some anterior mitral valve leaflet that's being sucked in to the left ventricular outflow tract, limiting the outflow tract between the hypertrophied septum and the anterior leaflet of mitral valve, causing a high turbulence, high velocity jet to occur, and this is where the gradient occurs. Let's show you another image. And so we've got many ways of looking at this and many views, but in this particular view, you can see the aortic valve is perfectly normal. We found that we surveyed like 7 patients in anticipation of this presentation and found that the diagnosis had been missed in 4 out of 7. So it's frequently missed diagnosis. And as far as I'm concerned, in terms of making the diagnosis, it's frequently finding hypertrophy on echo or EKG in the absence of a history of hypertension, unless you're dealing with the elderly who have a 60 to 70% incidence of hypertension in their 70s. The other hallmark is you hear an obstructive valve sound, murmur at the apex and left sternal border that sounds just like aortic stenosis. You say, this patient has severe aortic stenosis. And then you feel the pulse and you say, wow, that's a bounding pulse for aortic stenosis. That's kind of amazing, and that makes you think twice. You can clearly see this is a tricuspid aortic valve that has nice gossamer leaflets, and they open really well and have normal range of motion. Actually, this picture can be used for measuring the aortic valve area in people with aortic stenosis. It also is a great picture of the right ventricular outflow tract, which can also be narrowed in patients with HOCM, where they have a narrowing that occurs subvalvular on the right side. This patient doesn't have that. More information looking for abnormalities of the ventricle in terms of gadolinium enhancement that can occur with edema, and so we looked for that and didn't find that, which is called T2 weighted. And let me get through these real quickly for you. And of course, we always look for late gadolinium enhancement, and we also can give you images, and there's nice contractility, ejection fraction. We can give you images where we put a grid on the left ventricle, and we look for deformation of the left ventricle. And this is particularly useful for measuring strain. That's not unlike the strain seen with 2D echo with the strain package, but actually it's superb at measuring strain, and having access to many windows makes it easy that you don't miss strain on the patient, as opposed to echocardiography, where about 30% you can't get adequate images for strain. Here's another grid, our tagged image, and we have capabilities of in detail measuring this tagging and color coding it and telling you if there's wall motion abnormalities. I just wanted to show you that because I thought that was very pretty. And then more left ventricular images. And let me see if I have a late gadolinium study again. Hang on here for just a second. Here's the phase study. This what looks like some hazy looking images actually shows the aortic valve in the middle, and we look at the aortic valve and we can actually measure the velocity across the aortic valve with something called phase and compute the aortic valve area as well as the subvalvular area, just like we do in echocardiography. And so these are what the pictures look like when we do that. Pictures look kind of nonsensical if you're not used to seeing these images. And we've got both phase, and then we've got an image that shows us our exact anatomical location at the time that we're applying this phase. And here is our final image where we're looking for late gadolinium enhancement. And this is where we see that apical thinning. There is some brightness there, and that may represent scar tissue on this particular image, which is much better. We got a lot better at doing this 4 years later. And so this may represent a tiny apical infarct without remodeling and just basically non-contractile. Looking in the septum for a scar, and there's some little places in the septum that could be some little scars in the septum. Let's go look on the short axis view. Don't have a short axis. So we're looking again at the long axis. Late gadolinium enhancement. There's our scar tissue. There is scar tissue in this study that shows you can get some variation in the studies. We certainly got a lot better in 4 years, and I think this represents an apical infarct where the muscle outgrew its blood supply. Okay, and now we'll switch you back to Melody.
No. All right, guys. So thanks to Dr. Harrison. But it's now 8 o'clock. I know you guys have patients to see and lives to save, so we'll let you go at this point. Let me put up my last slide that has my contact information. If you have any comments, questions, topics you'd like to address in the future, please feel free to let me know. This will be an ongoing weekly webinar, and we will be covering many different topics, basics of various imaging modalities, and hope to see you there. So. Okay, Dr. Harrison says there will also be interesting and mystery cases, so don't forget to join us next week at 7 o'clock, and thank you all again for your attention. Any questions, please feel free to ask.